Let's first maybe a quick round of applause for Jason, Mary, Neil for really, I think, teeing this conversation up very nicely. And I think we have a microphone again out in the audience, and would be more than happy to take questions from the audience. But I do have some that are prompted by the materials that you've presented today. It was nice to see, Mary, the data that you had about overcoming some of the disparities that can arise as a consequence of making available new venues of care and not knowing about how we overcome those disparities, and seeing that the deployment of the technology actually helped with that. But that's one type of disparity. There's the geographic disparity. There's the access to the technology disparities that can arise. Can you talk a little bit about what are the barriers to understanding and measuring and studying disparities that come up in our current environment, and how they might be amplified by the telehealth space?
Sure. I mean, I guess I'll just sort of reflect on the questions, but I think that the issue of health disparities broadly, and also sort of the digital divide and access to technology, are sort of very large things that we're all struggling to do our best to address. Mm-hmm. I think that what we saw is at least what we would hope, that while there are persistent differences in access out there to technology, we hope that the technology itself is fairly agnostic to patient characteristics. And so what we see is that once patients use it, and I didn't have a chance to present these today, but we have some newer findings that we'll be publishing that show that once patients essentially are able to gain access to the technology, that means through a device and having the right, internet signal and having a camera or whatever is necessary in order to engage with the portal or any given telehealth technology, that they report, and these are again self-reported data, they report similar benefits, that it sort of engaged them, that it gave them greater access to their own information, that it was convenient. And so we're a little bit hopeful that as the needle continues to move in terms of technology access, that will sort of help level the playing field somewhat. And I know that that's a very sort of complicated issue. And there are many barriers out there, but we're sort of hopeful in this direction.
Okay, great. Neil, by the way, I've been out on the ocean days from access to care, and I do know what telex is because I'm a bit older than you. But it raised an interesting question in my mind. A good deal of the research to understand the benefits have been done in the context of those sort of, this is a substitute with what we presume to be the first choice, so rural environments or other access barriers that can be overcome, as sort of a secondary alternative to what we would believe is better, which is face-to-face. Now, that shapes the nature of the questions that you ask, and I'm curious whether you see opportunities to, for future research, understand not just how it compares to the standard, but how it might actually be a better alternative than the standard. Could you speak to that a little bit?
Sure. I think you're right. Finding that comparator is really important, and figuring out what you're trying to measure in the end game is sometimes helps you walk back to the right question. And we know that, I think it was mentioned earlier, that we learn things on telehealth encounters that you would never have the opportunity to learn through an in-person visit. Things about the environment, things about what's going on at home, maybe engaging a family member. So, I think that's really important, is to think about not always looking at, we have to disrupt the whole way we're thinking about a visit and rethink about the visit itself. And therefore, when we look at the comparator, it could be something completely different than we think about today.
Mm-hmm. Jason, you spoke about the framework of measurement and understanding, and I think that's a particularly interesting thing, because if we take any lessons from today's conversation, we will actually be seeing broad deployment of these capabilities before we know all of what they will do. So I'm curious your perspective on how thoughtfully creating a measurement framework will help us actually to better understand the impact that it's going to be having on the quality of care, and how we can draw from that lessons about how we adjust and change and expand or reframe the way we use these venues of care so that they're actually driving the kind of results that we want.
So that's a great question, and you know, I think we took a lot of lessons that were learned from past framework projects, particularly around health IT, in which sort of the premise was there's a new technology solution or there is some newer technologies that need to be adopted. Let's push forward a framework that will accelerate the adoption of those technologies, because in the end, they will provide better, more reasonable care. Telehealth's been around for a long time, and we can debate whether it started in the 1800s or not, but it's been around for a while. So it's not anything that's new. What's happening that's new is there's greater innovation. There's more increase in digital health. There's more increase in wearable technologies. Patient portals are being used more frequently. Video conferencing has greatly improved from what it was. I'm old enough to remember when we were first using the internet for education in the mid-90s, and the quality was awful. You can laugh at that, it's fine. I'm that old. But you know, now it's greatly improved to the point where the video is extensive. And so given that telehealth's been deployed, I think it's okay to allow the innovation to continue to proliferate. But I think what we have to take a step back in is, even though telehealth's been around, even though there's so many technologies around it and different modalities of care, there does have to be a way of sort of measuring what telehealth can provide and how telehealth impacts quality without changing or inventing new quality measures. Because, you know, there are 600 plus NQF endorsed quality measures. There are 2,500 quality measures overall. There's a lot of measures. And the last thing we want to do is be creating more measures. We want to take the measures that are already out there and really think about how do those apply to telehealth. Where could telehealth actually have the same, where can we measure it in the same way we would measure an in-person encounter? So that way the outcome is independent of care delivery system, it's just being evaluated. And I think when we start with a framework and a guide, I would say the wisdom of our committee, and Dennis, you're welcome, is that, you know, they narrowed down, out of all of the possibilities of things that telehealth could do, they said there are 6 things that are really, really important. You know, care coordination and empowerment and access and actual information and timeliness and travel. Those are the things we should start with first. And if we develop sort of a core set of measures around those, and then out of all of those measures that are existing in terms of clinical quality, pick out the ones that we think would be applicable to telehealth, and we come up with a core set, you're evaluating telehealth even as innovation is continuing, even as it's proliferating, even as CMS changes its reimbursement rules, which it just did 2 weeks ago when they added 14 new reimbursement codes for various clinical services in telehealth. And Adam Darkins, your former colleague who was also on our panel, Neil, you know, made a big point of this, which is telehealth's going to continue to go. We're not stopping it, and we need to let it continue to flourish. But we at some point in time have to put a framework together so that we can actually show, as Helen put it, again referring to Helen, real world evidence of how it's working, not randomized controlled trials, no offense to the researchers, not you know, systematic reviews of literature. Not that I'm knocking those are all wonderful. We use a lot of them as our foundation, but real-time evidence of here is how telehealth decreases travel costs. Here's how it provides actionable information, greater timeliness of care, and so forth.
Yeah, that brings up another interesting dilemma that we face, I think. We have this very interesting sort of standoff when it comes to telehealth. We have patients with regards to video visits who are apprehensive about being seen in their own environment and being self-conscious about that. So there's a barrier there. We have providers who are concerned with the flood of new things that they feel that they might need to have to do in order to respond to emails and secure texting and video visits. And the very real challenges there. And we have folks responsible for the financing of these things feeling anxious about the idea that they'll unleash a flood of new services being used. And yet, we've got a demand environment where those things are beginning to happen. That complicates research, because you can't even create a controlled trial because the environment is so uncontrolled and changing so rapidly that it is difficult to get insight. So from your perspective, and I would say from any of you who have thoughts on this, how do we come to know the impact of the introduction of these new technologies broadly deployed when the cycle times are that fast, the standoff between all those stakeholders is so significant, and the momentum is gaining strength? Any thoughts?
I mean, I would say this, that's not the first time that question's been posed to me. And I think that what I've said is you can't really look at telehealth in a vacuum. And what I mean by that is you can't assume deployments are equal across all populations or all age groups. So, for example, my parents who are in their 70s will never use telehealth. I mean, granted, they don't really understand what I do for a living, but regardless of that, they would still never use telehealth. They feel more comfortable seeing somebody in person. My daughter, on the other hand, who is 14, would much prefer to use text messaging and video conferencing for any hospital visit she could ever have. If it doesn't mean she has to leave her room and she could continue to listen to whatever emo music is popular on that day, she would be happy to be doing that. And I think you have to evaluate it that way. Like, deployments across populations are very, very different. In the elderly population, there seems to be more of a focus on perhaps using telehealth as an adjunct to in-person care, whereas for millennials, I think there's a preference of using telehealth as the primary source of care and in-person care as the adjunct. And so I think you have to frame studies and evaluations that way, not just broadly in a vacuum, but really the demographics and population characteristics.
Mm-hmm.
Yeah, I agree completely. I think there are a whole lot of small RCTs out there of really specialized tools, but we similarly, I think, agree that there's a lot of room to look at the real-world implementation of telehealth. And you're right, there isn't a perfect comparison group, but there are a lot of statistical tricks that we can use to do our best to account for patient characteristics, and we do need to look at sort of how patients are making their choice, that it's not a replacement tool that's sort of offered as a direct replacement. Really, it's sort of a patient option where patients can select where it fits their own preferences and their own possibly sort of travel barriers, they can engage in it. And so we're trying to think about it in a real world setting. You're right, there are challenges, but I don't think they're insurmountable at all.
Okay.
Brief comment. I think just the fact that we're talking about it beforehand is really important, that we're trying to measure something as we start new things, right? When we started treating whatever, we started treating hypertension, we didn't think maybe necessarily forward about the fact that we're treating hypertension through this vehicle. It came to my office, at this site and this site, and there was a difference. So it's the same idea. I think this is a new vehicle, and we're all being thoughtful about how we implement, at least at the beginning, small projects. Everything starts with a pilot. It seems that, and so we're thinking to measure the effect of this in some way, and just the fact that we're doing that is important.
So I'm going to keep some of my own questions in reserve in case I need them at the end, because we're starting to get some questions from the audience. If you could just introduce yourself real quickly before.
I'm Dina Peskin. I am the founding director of the Office for the Advancement of Telehealth in the federal government, and involved for many years, starting in 1988, with the development of telehealth programs. So I have a somewhat historic perspective. I certainly appreciate the panel and everything that's been done and you've done so far. To me, and working in early days of measurement, it was very important to ask the right question. And I sometimes think we're asking the wrong question in the context of telehealth implementation. So, for example, in mental health, early on, we found out that video interactions with certain kinds of patients were actually much more effective than in person, because the patient can control their sense of how far the practitioner looked to them, and their comfort level was much greater. We learned this in the 80s. Another example is emergency care. the idea that we're going to, in rural areas, save an emergency transfer. Well, actually, at Fletcher Allen in Vermont, what we found, and I think we found it over and over, is that sometimes we did, but more importantly, the information that was transferred with the patient before they arrived at the higher level hospital was critical to the outcome of that patient. So sometimes avoidance, asking the right question in the context is very important. And finally, as another example, in chronic disease monitoring, the issue may not be whether patients are as happy or whatever. That's a very critical question. But another question is, how long do they maintain monitoring? Do they do better with using telehealth in terms of how long they maintain a high level of their monitoring and then what the outcome is, so ultimately? But the length of time you follow, so many studies are for 3 months, 6 months. What you want to know is what happens over the longer term and what your interventions are. So I just want to raise that because in the context of measurement and the broad measurement, as you apply the measurement to indicators, ultimately, the right question is very critical. Otherwise, you just say, well, did it save money? Well, is that really the question? It's one question.
Well,
I'll
yeah,
stop.
go ahead.
I think that brings up a good point because it sort of dovetails, Dina, with what a question I've got quite a bit as I've spoken, which is, well, what are you going to do now? Like, you created the framework, so what's next? Like, that's great. What's going to happen? And so I think the next thing that has to happen is that measures need to be developed from the framework. So how do you go about doing that? Do you do that sort of abstractly, which is you use the framework as a guide and develop measures and then put them forward and say, okay, everybody, here's what you use? Or do you take another approach, which is my colleague Judd Hollander said, to go pressure test the framework, which is to go to telehealth resource centers or to go to telehealth programs and look at the measure concepts and see how they apply to these programs. Would they actually provide a metric that would be valuable in assessing its effectiveness? And the only way you are able to determine that is if you're asking them the right questions. If you're saying, how do you evaluate timeliness? How do you evaluate access? And seeing if their answers align with those concepts and if the concepts have to be altered. And then once you have that done and you have those concepts created and you build use cases from those concepts because of the information you collected, then you can develop measures that hopefully will cut across all the telehealth programs because you've done exactly what you said to do, which is you've asked the right questions and you've applied the framework in ways to know where the adjustments have to be made by looking at it in real world situations.
Yes, another angle on that issue of question comes to mind, and that is if the objective is to improve the quality of the decision in the moment. In other words, a patient comes to one of these venues and is trying to find out, is there something I can do at home and stay there? Do I need to go to some other venue of care? Do I need to supply some additional information? Has there been any research, or are you aware of any research that looks into the impact on decision making and whether it's a higher quality decision, and that higher quality decision may actually to use more care because someone would have decided to stay home when it was critical for them to go in? Anything that you're aware of in that vein?
I'll make one comment on that. So I mentioned the secret shopper study, and I think if you look at that, one of the scenarios was back pain. Now, so the guideline is for patients without traumatic back pain not to get an X-ray. So there's an inherent bias, I think, in this question, right? Because if there's someone on telehealth and it's, you're looking at a non-integrated type of online delivery model, and you're measuring how often the provider recommends getting a lumbar spine X-ray and non-traumatic back pain, and it's better or lower in the virtual visit than it is in the in-person visit. The question is, was that visit really better or not? Because it's inherently biased in the mechanism of ordering. So when you look at test ordering, when you don't have access to tests, there probably will be lower. That's the insight I have, but I don't know the answer.
Yeah. The venue creates a set of options that might not be available in another venue, or vice versa. Okay. Yes.
Hi, Patricia Lynch from Kaiser Permanente, and maybe Dina, who was in front of me, wants to contribute to this as well. There's been a lot of exciting conversation today, and about the use of telemedicine as just a clinical tool and an extension of regular clinical care, and not something separate, of which you showed some pretty compelling evidence. But on a policy level, we've been having trouble, particularly with the federal government, in trying to address requirements around network adequacy as we provide coverage to people. Looking at, they still look at time and distance, which is we call doc on a block, where you have to show, you have to just contract with lots of physicians and don't take into consideration the elements of quality and access, and really the offering of telemedicine as part of the product is not generally taken into consideration. And states have less of this issue. It's really at the federal level. And you may be the wrong people to ask, but I'm wondering if you have any ideas as to what sort of data points we could develop that would help to move our policymakers away from a fee-for-service centric measure of network adequacy to something that looks at really what serves the needs of the patient and provides a quality experience.
So my immediate recommendation is to look at the framework that was created, because the effectiveness domain talks about a lot of that, particularly the technical effectiveness of telehealth. It does speak to network adequacy, and that is a significant problem, because in these presentations I've had conversations with an awful lot of rural health providers and nurses and pharmacists and people that are in incredibly remote areas. So I was talking to a group that was running a clinic in the northernmost part of Arizona, right up against Utah. I mean, there's no hospital anywhere near them, and they just got fiber optic. I mean, they were running T1 lines. For those of you that don't know the history of the internet, T1 was fast 2.5 decades ago. I mean, that would be the equivalent of dial-up right now, without the annoying noise that we used to get when you did dial-up. And so the fact that they just got broadband shows that pockets of network adequacy are existent. So you have to be able to evaluate that. You have to be able to assess, is the network reliable enough to deliver the services that they intend to serve? And I think the way to sort of drive policy in the government on that space, which agreed that they really look at it very much in a fee-for-service model, is to show where there is inadequacy and what the effect of that's going to be on a variety of clinical components. Particularly mental and behavioral health care, which is mostly almost all video conferencing. If you have a T1 line, you're not doing video conferencing, not without significant buffering or numerous interruptions. And in those areas where they've said children and adolescents in particular desperately need effective telemental health, particularly because of the disorders that they consistently see, which are depression, anxiety, eating disorders, substance abuse. If they don't have the network adequacy to deliver that services, then they're going to fail to meet those quality metrics. That, to me, is how you start to drive policy. And that was sort of, again, the wisdom, Dennis, you're welcome again, of the framework by creating those effectiveness domains in the technical area to really assess that adequately and objectively.
Neil, you may have a unique perspective on this, given what you were saying about the maritime. I mean, that's a network adequacy challenge, isn't it?
Yeah, I mean, I guess there's a parallel there. I mean, we're really focused on kind of inertial and early stabilization, so that's the ER as the hub. But then our network is a international, global, unknown, right? Because we're looking at different ports, and we're trying to compare that to what is U.S. standard of care.
So there's a rather broad question that I want to ask, and maybe have each of you respond. And this goes to the public policy and maybe how we as a nation organize our availability of funds to do research. What do you think would need to happen to the way we fund research, whether both privately and publicly, that would give us the availability of funds to really answer some of these difficult questions on the timelines and cycle times that we need to when the pace of change is so rapid. Any thoughts on that?
Well,
Giving you a
it's hard.
chance to ask for money for
My
research.
disclosure is I'm a researcher. And so my answer feels fairly obvious. I think as a health services researcher, there are, and especially one embedded in a really rich healthcare delivery setting where there are a lot of questions that could be asked and answers that could be offered to the broader, U.S. research community and healthcare delivery community, that where funding is a real obstacle, I think. And I think we can't answer all questions, and there are a lot of things that still will be challenging, and no one can predict the future. But I think there are a lot of things that could be answered through high quality, sort of rigorous research today if we were to invest in that kind of funding.
Yeah, I mean, obviously that's true, and I think it's important for the funding agencies to kind of recognize that this study of telehealth is kind of as important a question as some of the basic science questions that we are pursuing. And so it's really kind of elevating kind of the critical need for this. I mean, the more and more every day, right, everyone's saying telehealth's happening, right? 5 years ago, people are still kind of like, well, what is telehealth? And now I was interviewing residency candidates yesterday, and they're like, well, telehealth's going to happen, so you guys are going to train me how to do telehealth in my residency, right? And I'm like, yeah, we are, but a lot of places aren't yet. And so as that shift is occurring, hopefully that escalation will occur as well.
I think just sort of echo what I've said before, which is it really needs to be real-time based. I mean, I think you need to have real-time evidence, real-time metrics that really show where it is effective, where it is not. And I think also where's the greatest need. So, again, conversations on this topic have said that while I think the framework that was created has been, enthusiastically received by the telehealth community, which we're grateful for, they've also asked, could we do smaller frameworks on telehealth, on mental health, on stroke, and on chronic disease management, because those are the areas they see the most frequently. And having a core set of metrics that evaluate telehealth services in those areas would be valuable. And providing real-time evidence and real-time metrics on those services, as well as telehealth as a whole, I think drives research because it drives improvement, and it also meets the market need at the moment.
Great. Well, we are coming down to the end of our time. Really, really appreciate Neil, Mary, Jason, your time, your insights, your experience, and your advice about work coming to understand what it is that's actually happening in the telehealth space. So thank you very much.